So we're going to focus on venous disorders, and you can find this information in chapter 37 of the Lewis textbook. So we're going to talk about phlebitis. Phlebitis is the inflammation of vein walls. It can be found in the upper or lower extremities. We're going to focus on the upper extremities. Close to 27 to 70% of all patients with IV catheters are at risk for developing phlebitis. Risk factors include a peripheral IV catheter, the location and size of an IV catheter, and any medications that can irritate the vessel wall. It's going to occur more frequently with cannulation in the antecubital area or the bend of the arm. Manifestations are going to include pain at the site, minimal swelling, erythema, warmth, and a palpable cord. Treatment methods are going to be to remove the catheter, assess for venous thrombosis development, keep the extremity elevated, use warm moist heat, and the use of oral or topical NSAIDs such as Voltaren, ibuprofen, or Indocin. In the event that bacteria has infiltrated the site, it's known as a septic phlebitis, and we would also, in addition to the other treatments, use antibiotics. These are just some pictures that show the clinical findings of somebody with phlebitis. This is a tool that nurses can use to guide their practice in the event that somebody has been diagnosed with phlebitis. It's a grading scale from 0 to 4, and it's based on severity of symptoms. And this is not something you need to know for the exam. I just want you to know it's out there for practice. So venous thrombosis. So it's the formation of a clot or a thrombus in the vein, usually associated with phlebitis or that inflammation of the vein. So there are two classifications, either superficial or deep. Superficial can lead to a deep vein clot, and superficial is normally considered benign, but more currently, research has found that 25% of patients who are diagnosed with a superficial clot, they also at diagnosis have a deep clot. So deep clots can be found in the iliac, femoral, or popliteal veins. They can be upper or lower, but only about 5 to 10% are in the upper extremities. Most are in the lower extremities. The term VTE, or venous thromboembolism, refers to the spectrum of pathology from a deep clot to a pulmonary embolism, or PE. So factors called Virchow's triad contribute to the formation of a clot. The three factors are venous stasis, endothelial damage, and hypercoagulability of blood. So venous stasis, any condition that's going to lead to pooling or reduced circulation. This stasis of blood is going to increase a patient's risk or chances of clotting. Any condition that leads to damage of the intimal lining of the blood vessel that increases a patient's risk of platelet aggregation is at risk for developing a blood clot. And any condition that's going to increase the body's capability to clot is going to cause a risk factor for DVTs or PEs or any type of VTE. So the pathophysiology of a clot is there's going to be an aggregation of platelets and fibrin that traps cells, which is going to form a thrombus. As the thrombus enlarges, more clots and more cells and fibrin are going to collect behind it to make it bigger. Eventually, the lumen has the capabilities to completely occlude a vessel, which is going to lead to the symptoms that we see. In some cases, a clot is going to be able to organize and detach and result in an embolus or an emboli. And usually it's going to go to the right side of the heart and into our pulmonary vasculature. Increased blood flow or turbulence can influence the risk of embolization. So a superficial clot. So some of the risk factors are the same for the risk factors for VTEs, which we already talked about. The manifestations may not be quite as severe as somebody who's got a deep clot, but still enough that they know it's going on. So they're going to have that palpable cord vein, itchiness, tenderness, redness, and warmth at the site. Some cases where the inflammatory response occurs, there's going to be an elevated temperature, increased white cell count or leukocytosis, and there might be some minimal unilateral edema, but that's going to be more commonly seen with somebody who's got a deep clot. So collaborative care, we might do a duplex ultrasound. That might be to diagnose the clot, and it also might be to see if the clot has progressed to a deep clot, to assess location, to assess how aggressive it is. In the event that somebody has a superficial clot in the leg, we're going to do heparin times 45 days. We also are going to use oral or topical NSAIDs. We're going to use compression stockings to improve circulation and to reduce the edema. And we're also going to use mild exercises for the same reasons, and also to decrease the risk for the clot progressing or more clots from developing. So a VTE, so a deep clot can be found in the lower extremities. Like we said, only 5 to 10% are found in the upper extremities. Manifestations, you're going to see unilateral edema, tenderness, and because the manifestations are deeper and they're so much more severe than a superficial, we're going to see dilated veins. There's going to be a sense of fullness or heaviness in that area. We're going to see paresthesias, like the arm is falling asleep. We're going to see warm skin, erythema, and we are going to see that elevation in temperature just secondary to that inflammatory response. Complications of a VTE or deep vein thrombosis is going to be a PE or something known as post-thrombotic syndrome. So post-thrombotic syndrome can occur in up to 50% of patients despite adequate anticoagulant treatment. This can occur months to years after a patient has had a blood clot, a deep vein clot. Some causative factors, there's going to be chronic venous hypertension or pooling in the venous circulation, and it's going to be caused by destruction of the valves and non-compliant vein walls. And that's going to be caused by the seriousness and the severity of the blood clot that we had. Okay, so this is a complication of a blood clot. Manifestations are similar to what we saw when the patient had the clot. They're going to have heaviness, swelling in the extremity, itching, tingling. They're going to have increased pigmentation or increased integumentary changes in that leg, and they're going to have increased varicosities. Some risk factors are as if a patient had blood clot symptoms greater than 1 month, if the clot was large and extensive and the physicians had a long, hard time getting rid of it, if the clot was recurrent, if the patient continued to have more clots in the same area or location, advanced age, and female. These are just some pictures of the changes of somebody who has post-thrombotic syndrome. Some diagnostic tests that we might see in either the diagnosis or the continued assessment of somebody with a blood clot. D-dimer is the standard laboratory test to diagnose somebody with a venous thromboembolism. The positive result is going to show the breakdown of fibrin or the breakdown of clot. Okay? So the result is a fibrin degradation or fibrin lysis. Okay? So most often if a patient comes in with severe manifestations or symptoms of a pulmonary embolism or a blood clot in the leg, we might skip right over the D-dimer and go to an ultrasound or go to a CAT scan. But in some patients where the symptoms are very mild and we might think that doing a simple blood test might be the answer. Because if the test is negative, then we're not going to go to anything else aggressive. So other blood tests like PTT, a PT-INR, hemoglobin, hematocrit, and platelet count. We're going to do these to assess for bleeding in the event that somebody is on medications for their blood clot. We're going to assess the patient's risk for clotting, or we're going to assess to see if the medications they're on are working effectively. Some non-invasive tests that are kind of the gold standard to diagnose or assess a blood clot is going to be a venous compression ultrasound or a duplex ultrasound. It's going to assess the compressibility of a vein, and it's going to assess blood flow and filling defects in the vasculature system. It's going to be one of the most widely used tests. Veins should typically be easily compressed, and in one of these ultrasounds, the technician will take the wand and will compress it on the vein, and if the vein is difficult to compress, most often the diagnosis of DVT can be made, in addition to evaluating blood flow and some filling defects into the venous system. A more invasive test that could be done is a CT venography or CT angiography. This is where contrast dye is going to be injected into somebody's IV, and then a CAT scan is going to be done to look at their vessels, or even like their pulmonary vessels if we suggest or think somebody has a pulmonary embolism. It's a much more invasive test. Because we're using contrast dye, we do worry about the patient's kidneys. We do worry about allergic reactions. These are just some findings on the right of somebody who's had a CT angiography and has looked at their pulmonary vessels. You can see the arrows point to the locations of the clots. On the left side is pictures of somebody with an ultrasound. There's a compressibility ultrasound, and there's also a duplex color flow where it shows blood flow and it shows compressibility of the vein. So some medications that we're going to use either to prevent or treat blood clots, including a vitamin K antagonist or warfarin or Coumadin. It's going to inhibit the activation of specific clotting factors. It has a long half-life, so the onset is 48 to 72 hours, and it may take several days to achieve maximum effect. The lab levels that we're going to use to measure the effectiveness of Coumadin is going to be the PT-INR. The INR is noted as the Internationalized Normalized Ratio. It's a standardized system for reporting the prothrombin time. So usually when a physician orders blood work to assess Coumadin effectiveness, they're going to say PT-INR. Usually treatment is guided based on the INR level. In a typical range for somebody who's on Coumadin where we want to see the INR is between 2 and 3. In the event that the INR is too elevated or the Coumadin is too effective, we do have an antidote, and it's called vitamin K. It can be given orally, sub-Q, or IV. In emergent cases, it might be given IV in the event that the patient's going to surgery. There's elevated INR with significant bleeding. These patients might get vitamin K IV. But in more cases, we're going to give it by mouth or we're going to give it sub-Q for better effectiveness. Some of the nursing considerations that we might consider in the event that a patient is on Coumadin: we don't want to give any antiplatelets or NSAIDs concurrently with warfarin. Antiplatelets might be Plavix, aspirin, NSAIDs, ibuprofen, Indocid. It's going to increase our risks or chance of bleeding in these patients. Any types of alternative therapies that may interact with warfarin, whether it's going to decrease the drug's effectiveness or increase its risk for bleeding. In the book, there's a long list. Here, there's just a few, like ginger, vitamin E, and soy. We know that green leafy vegetables have vitamin K in it. So a lot of prior evidence told us that patients on Coumadin should stay away from green leafy vegetables. What more of the evidence is telling us now is that patients should eat a well-rounded diet. They should minimize large quantities of vitamin K content food. But they should try and stick to consistent daily diets where they're not making large changes in the kinds of foods they're eating. It's much better to control a patient's Coumadin dose and monitor their INR if patients are eating very consistent foods daily. Another anticoagulant is a thrombin inhibitor, as indirect, is heparin or Lovenox. It's going to infect the intrinsic and common pathways of blood coagulation. It's going to inhibit the thrombin-mediated conversion of fibrinogen to fibrin by affecting multiple clotting factors. It can be administered sub-Q or intravenously, prophylactically, or for treatment. So when it's given for treatment via an IV infusion, we must monitor the PTT, or the activated partial thromboplastin time. Typically, we'll do this every 6 to 8 hours until the patient has a consistent level, and then we might do it daily until the patient is off the heparin. There is an antidote for heparin. It's called protamine sulfate. It's typically not used, and that's just because heparin has such a short half-life that once the medication is turned off, it's out of your system pretty fairly quickly. So in only extreme cases do we use protamine sulfate. So some of the nursing considerations, when a patient is on heparin, we're going to look at their platelet count. Patients are at risk for developing something known as heparin-induced thrombocytopenia. This is an allergic reaction. There's going to be a decrease in platelet count, and there's going to be immune complexes caused incorporation with the platelets that can actually cause microemboli in the venous and arterial vasculature, and it can cause clots and decreased perfusion to extremities and organs. And these patients that we suspect they have hit, we're going to do blood work to assess to see if there are antibodies to platelets. They're called HIT antibodies. We're going to stop their heparin, and we're going to document the heparin as an allergy because these patients should not be getting this medication again. In the event that somebody does have an allergy to heparin and they are HIT positive and they have these microemboli, we're going to use a medication called argatroban. It's going to reversibly bind to thrombin active site, and it's going to enable fibrinogen conversion to fibrin during the coagulation cascade. It's indicated as an anticoagulant for prophylaxis or treatment of blood clots, especially in patients with HIT or heparin-induced thrombocytopenia. So it's going to work without causing any alterations in the patient's platelet count. With somebody who's on argatroban, this is an IV infusion, we're going to monitor the drug using the PTT level as well, the same one that we would use in somebody who's on heparin. So there is no antidote if bleeding occurs or if we need to reverse the effects of this drug. So it typically has a shorter half-life, maybe not as quick as heparin. In the event that a patient has hepatic impairment, we're going to adjust the dose because it is metabolized almost entirely by the liver. So we need to be careful in these patients because there would be a higher buildup of the argatroban, increasing the patient's risk for bleeding. Another medication that we might use as an anticoagulant is a factor Xa inhibitor known as Xarelto, and this is a by-mouth medication. It's going to be used for both the prevention and treatment of venous thromboembolisms, or emboli. It's going to inhibit platelet activation by selectively blocking the active site of factor Xa without requiring a cofactor for activity. The good thing about Xarelto is that there are no drug levels that need to be monitored, and there are no interactions with foods. So patients can eat what they want, and they don't have to have blood levels monitored. So in addition to bleeding is a side effect, which is with what all anticoagulants is the risk, it can cause significant dizziness. So being that it's an oral dose, similar to Coumadin, we want to make sure that we take it at the same time every day. And just like with argatroban, we're going to adjust the dosage in patients with renal or hepatic impairment because we don't want the drug level to build up in their system. So some of the assessment findings or assessment information that we might look for in a patient, subjective information. We might look at pain. Are they having chest pain that might indicate a PE? Pain at an extremity that might indicate a blood clot. Typically in patients with a pulmonary embolism, they have a lot of anxiety. We're going to look at their medications to see if they're on oral contraceptives or estrogen replacement if they're postmenopausal. We're going to look to see if they're on any alternative medications. Are they on synthetic erythropoietin to stimulate red blood cell formation, known as Procrit? It increases a patient's risk for blood clots. We're going to look at any pertinent health history, histories of cancer, recent IV placement, and we're going to look at some objective findings. Are they febrile? Is their white count elevated? Do they have unilateral edema, and have we measured their calf circumference? Have we done diagnostics? Do they have a positive D-dimer that might suggest a patient has a blood clot? It shows fibrin lysis. Do they have a positive duplex ultrasound? And what's their CT of the chest show? Are they positive or negative for a pulmonary embolism? So some of the nursing diagnoses that we might see with a patient for a pulmonary embolus or VTE, DVT, is acute pain related to venous congestion or the inflammation. Risk for bleeding if a patient is on anticoagulant therapy, especially if the patient's blood is too prolonged, putting you more at risk for bleeding. How knowledgeable is the patient? Is there an ineffective health maintenance related to lack of knowledge about the disorder and its treatments?